Hi. I'm so glad people are joining us. I'm waiting for Mimi to come on. Dr. Mimi Knoll is going to be joining us. And then as soon as she joins, we'll hopefully connect both of us on the live and be able to get right to your questions because they were wonderful and there were many. Okay, I'm just like I said, I'm waiting for Dr. Mimi Knoll to join. Oh, I think I see her. Let's see if we can get her on. Mimi, do you want to send a request? 1 second. Not sure why it's not letting me invite you. Hi. Do you want to just request to be in the live? Hit request, because I'm not sure why it's not being so nice to me right now. Oh, here we go. Okay, we're waiting.
Hi.
And you're on. Amazing. I'm so glad.
How are you?
Yes, I'm so glad that we get to do this. I know that we are.
Yes.
We've got flooded with questions.
Oh my gosh, I know. This is so exciting.
It really is. And I think that it signifies just how much people want to and need to talk about it. Like there was a part of me that felt so sorry for the fact that we're all walking around carrying so many questions. And really there are good answers to these questions, but it's hard to find a resource to be able to just say, well, I've got this question, how do I get answers? And we'll talk about those resources later, but I'm really glad that we're able to do it on this platform. I also want to say, and we did speak about this a little bit before, that part of the agenda of the live, if I will,
yes,
for those of you just joining, part of the agenda of the live is that we're going to open up possibly more questions for you than answers, meaning to say, we don't know your particular medical history. We don't know exactly what's going on in your family. We certainly don't know a lot of the other circumstances that surround the question that you asked. So first of all, we will do our best. I'm sorry, my phone stand is acting.
Yeah, same for me.
Right, okay. So we don't have perfect answers for you, but what we're hoping will happen is that hopefully through the questions that other people ask, through the questions that you have, we'll be able to hopefully get some of the conversation going so that you possibly can go back, whether it's to a genetic counselor or to your doctor, and say, you know, I heard this presentation and now I have, you know, kind of this follow-up question or this question. And hopefully they can then lead you to an answer that is right for you. So I just want to say that it's not like we're ignoring any particular questions. There were some questions that were very case specific that are going to be difficult, obviously, to answer when you're talking to a broader audience. And I'm sure there will be comments that will be coming in throughout. I will certainly be trying to look at them. And if there's something that needs clarification, we will try to clarify it. But if there are new questions on here, not necessarily will we be able to answer all of them. So now that I got all my disclaimers out of the way of what we are doing, why don't we start with just a basic overview about cancer and genetics? Because I think a lot of the initial, I'd say, first 20 questions were really, is lung cancer genetic? Is colon cancer genetic? Is brain cancer genetic? How do I know if this cancer, if there were multiple cancers in my family, how do I know what to test for? So give us just the basics first, and then we'll get into the specifics, mostly related to the BRCA gene and being the breast ovarian kind of cancer world.
Sure. Yeah, so I'm going to first also start with a couple of my own disclaimers, if you don't mind. So first of all, thank you for inviting me to talk about this. And you know, this is why I love social media. I know there's a lot of hate going on about social media, but you know, I feel like I know you even though we've never met. And you and I, you know, you texted me, you messaged me like, what is it, 2 days ago? And I said yes, and we're already doing this and being able to educate people. So that's the power of social media. So number one, this is social media, information purposes only. Like you mentioned, unfortunately, we won't be able to get to individual cases. Number one, because it's not safe or smart to answer medical questions, but also because, details are so important in cancer. So the details are everything. So what we'll be talking about now is not medical advice, but medical information. So it's used for information and question creation. And the second thing I want to mention is that, obviously our minhag is not to talk about you whenever we talk about something negative. But in this case, it's just so confusing to talk about another person. So when I talk about someone who's being tested, I'm going to be saying you, as in if you have a breast cancer or if your mother died, I'm not talking about you. It's not about an ayin hara. I want to be able to be clear when I speak.
Okay.
So okay, great. So talking about cancer and genetics. So this is something that is actually fascinating. It's what really fascinates me about cancer. And what cancer is an abnormal gene, an abnormal cell. There's no such thing as a cancer that doesn't have a mutation, because by definition, a cancer is a cell from the human body. It's your own cell. It's part of your body. But it grows and grows and grows, and it doesn't stop growing. And as we know, sometimes when it grows, it gets so big that it causes problems, and that's how we find it. Sometimes it grows so big that it starts spreading to lymph nodes or starts spreading all over the body, and that's when it's metastatic. But again, by definition, every cancer has abnormal genes. What we mean by a hereditary cancer or a familial cancer is a cancer that runs in the family, meaning one of the mutations of the cancer was inherited from a parent. Okay, so what that means is that we know that we get half of our genes from our mother, half of our genes from our father. So every single gene in our body, there's 2 copies, one from the mother and one from the father. And when somebody gets a BRCA mutation inherited from their mother or their father, which is important. It doesn't only have to be inherited from the mother, even though we think about it for breast cancer. What that means is that every single cell in their body has one normal gene and one that has the mutated gene. Now, you need 2 of them not to function to get a cancer. And this is for any cancer. But for when someone has one abnormal gene inherited, it's easier to get a real cancer because you only need the second one to become mutated instead of having to go through that mutation on your own twice. So again, every person in the world, their cells are always growing and changing and sometimes mutating, and the body is able to handle it by stopping the growth, by killing off those cells, and you never even know it. So our immune system is always fighting infections, I'm not going to mention coronavirus, but, cancer cells. Our immune system handles all these things every day without our knowledge. But when the immune system is not able to handle 2 copies of a mutation, that's when a cancer develops. So again, every cancer is a mutation by definition, but only some cancers can be inherited from one generation to the next.
It's so funny how pieces of this, but then it all comes together. That was amazing. So my question to you is, first of all, can we just get like a basic list of which are those cancers that can be inherited and which are it's a fluke if 2 people in the same family had it, but that's not hereditary, at least to the best of our research now.
Right. So most cancers, there is a syndrome or a familial case or case study. There are a few that are very commonly inherited, and the ones that are most commonly inherited are BRCA1, BRCA2. BRCA1 stands for breast cancer 1, just because that was the first gene that they realized was related to breast cancer mutation, and BRCA2 was the second one that they found. There are lots of other ones. There's ATM, there's PALB2, there's PTEN, there's TP53. There are lots and lots of them. The whole point of doing genetic testing for cancer is not just for information purposes. The reason to do it is if, and only if, there's something that we can do, right? So if somebody has a cancer and we have a suspicion that because they have it, someone else in their family could also get it or is likely to get it, that's a reason to test the person who has a cancer, because if they don't have it, we can have a sigh of relief, right? And if they do have it, we can say, well, let's potentially tell your family members, right, and have that discussion, because if they are at an increased risk of getting it, we can do things like encourage them to go for example, breast MRIs at a young age, start mammograms at a young age, have children at a young age so that they can potentially remove their ovaries and fallopian tubes, because if you don't have ovaries, you can't get ovarian cancer, right? So it's almost never just so that we have information. It's always because we can do something with that information that's valuable to the patient and their loved ones. There are some newer drugs now specifically for cancers that have mutations. So there are some times where we'll actually test the cancer itself or the patient's regular cells, meaning not the cancer itself, but the patient's regular cells, because if they have a mutation, they can be eligible for certain types of medicines that will only work if they have that mutation. So there are some drugs that were recently approved for ovarian cancer, for pancreatic cancer, because again, patients who have those cancers that are a direct result of those mutations, these drugs work really well, and there's no reason to take those drugs if they don't have the mutation.
Right.
So, and then there are other cancers that are hereditary, meaning if we look at a family tree, you know, this person has cancer, this person has cancer, this person has cancer, and maybe we'll never find the mutation, but there's clearly a hereditary component to it. And in that case, even if we can't find the gene, name the gene, we're still going to recommend, for example, colonoscopies at a younger age. Instead of starting at age 50, we'll recommend starting at age 40. You know, these are very general.
Just for a second, would you say that that's
yeah.
if one parent or one grandparent has that, or are you looking for multiple people in the family, say with colon cancer?
Right. So, you know, generally speaking, for colon cancer, if someone has a relative that had colon cancer, we would want them to start screening 10 years before the age of the person when they were diagnosed, or age 50, whichever one is younger.
Right.
So let's say someone was diagnosed at age 45, we would want their children to have a colonoscopy at age 35, right? But let's say someone had a colon cancer at age 65, all right, at 70, so we would want them at 60, but actually they needed to have started already at age 50, right? So, you know, anyone that has a cancer diagnosis in their family should be asking these questions. Am I at increased risk? Whether or not there's a mutation or a syndrome that we know about yet or can be diagnosed yet, or we know about already, you know, these are questions that every patient should be asking. Now, I think the reason why this has come up more recently, I know we had discussed, is that, you know, specifically for breast cancer and ovarian cancer, and actually we know now for prostate cancer, Ashkenazi Jews like ourselves, you know, are at a higher risk of having the BRCA1 or BRCA2, also known as BRCA1 or BRCA2 mutation, and therefore that's something that we should be thinking about even more than just the general population, because we have a higher chance of having those genes, and therefore getting a cancer because of those genes.
Got it. Okay, I want to move
because of those gene mutations, right? Okay. We all have the BRCA1 gene, we just don't all have the mutation. Yeah.
Yes. Okay. I want to move into some of the questions. I'm going to just swipe up for a second because I want to be able to just turn something on, because some reason the questions disappear from my screen. If it shows on pause, it's just that I'm turning something Oh, I should be able to access this file. For some reason, when my phone locked it from my opening it on my laptop, you know, we do funny things like that sometimes.
Yeah.
Okay. So now, as it's opening, okay. As it's opening, though, I do want to mention that there were a few questions about actually the Ashkenaz Sfarad thing. So just because you mentioned it, like, do Sephardic Jews need to completely ignore everything you say tonight?
Yeah, I mean, you know, Sephardic Jews don't have the BRCA1 or BRCA2 mutation. But, you know, many people who identify as Sephardi do have one or two, maybe Ashkenaz grandparents. So in that case, this does apply to them. So if you have an Ashkenazi grandparent, you know, you can still carry those genes. Obviously, the risk is lower, but it still applies if you do have any Ashkenazi blood. So that applies, yeah.
Okay. So I'm not sure why it's still a bit obnoxious to me. I don't know if you're able to open it. I just wanted to do this. So strange. I had it literally open as you were talking, and then it disappeared.
So somebody also just commented that there are other people that don't have BRCA mutations that are not Ashkenazi. That is 100% true. The BRCA1 and BRCA2 mutations are not unique to Ashkenazi Jews. There are many people with breast cancer in the United States and in other parts of the world that have this mutation. It's just that we're focusing on it because right, our audience tonight is Ashkenazim, but the mutation can be found in other ethnic groups all over the world as well.
Okay, wonderful. Are you able to open the file that I sent you, Mimi?
Let's see. I have it on my phone.
I'm trying.
So I think I have to close
I
that.
also have it on my phone, but for whatever
reason,
my desktop is being very obnoxious right now. Oh, here we go. Now, of course, as soon as I asked you that, it's opening.
Okay, great.
Okay, great.
Sorry, the live, somebody just asked, it's pausing just because we were trying to open up a file that we had prepared.
Yeah, and it was not being so cooperative. Okay. So I think, there was one question that we had kind of skipped over a little bit. How does birth control, what's the deal with birth control and increased risk with breast and ovarian cancer? I think it decreases one risk and increases in another, right?
Yeah, exactly. Okay, so birth control lowers the activity in the ovaries. Basically, it shuts the ovaries down. So because it shuts the ovaries down, it lowers the chance of ovarian cancer. That is something that we know to be absolutely true. Now, birth control does have small amounts of estrogen in it, and some breast cancers are sensitive to estrogen. So there's a question of whether breast cancer risk is increased for women that get that take birth control. The answer is we don't know. Now, the way that I like to explain it to my patients is, if there was a very big risk, we would know about it, right? Because everyone who's on birth control would get breast cancer, right? Everyone that has a BRCA1, BRCA2 mutation would be on birth control. They would come in with these big, bad, ugly tumors, right? That's not the case. That's not the case. There potentially could be a very small increased risk, but that risk is definitely outweighed by the improvement in risk for ovarian cancer. That being said, you know, it's something, again, that should be discussed if someone has a mutation, right? So if someone has a known mutation, you should discuss with their, oncologist, with their OBGYN, what the options are for birth control.
That
one
wouldn't
of the
increase the risk.
That would not increase the risk. Now, but again, women who have BRCA1, BRCA2 mutations are able to have children my friend Dr. Batsheva Lerner-Maslow is a reproductive endocrinologist, and I was talking with her just earlier today about how one of the things that they do to reduce the risks for women that have a known BRCA mutation is egg freezing, so that they can then, when they're ready at a younger age, have their ovaries and fallopian tubes removed. Right, so if the eggs are freeze earlier on, then they don't have to worry about having children as early, and then, right, so these things can get very complicated, and the answer is that if someone has any worry or family history or suspicion of having a BRCA1 or BRCA2 mutation, they need to see an oncologist, they need to see a genetic counselor and discuss what the options are. And I want to be clear that I'm not saying everyone go off birth control. That is not what I'm saying. Do not do that. But, you know, for women that do have that risk, it's something they need to discuss individually. But there's no hard and fast rule that, you know, all birth control is dangerous and causing, you know, all the breast cancer in the world.
Right. Okay. What about any fertility drugs, and also do PCOS cysts generally turn cancerous? Are they in any way related thing? I didn't think so, but I just wanted to put it out there.
No.
Okay. Now let's get to the real heart of the matter. When is the right time to begin screening for breast cancer? And is there a difference when there is a family history?
Yes, there is a difference when there's a family history. So the way that we think about it is like this. First of all, again, we're talking to an audience that is Ashkenazi women. Okay, so Ashkenazi women have a 1 out of 40 chance of having a BRCA mutation. 1 out of 40. Okay, that's a high percentage. That means think about your high school class. You know, my high school class was small. We were 24. You know, if you went to, you know, bigger base Yaakov, you know, a handful of the women that you know that you grew up with are going to have that mutation. So there are some people that would say that every single one of us should get tested, all of us. I think that's a very big deal to recommend. I don't think we're there yet. Mm-hmm. But certainly if someone has a relative, either a first degree, a second degree, or a third degree. Now let's talk about that. A first degree, mother, father, sister, brother, son, daughter. Second degree, grandmother, grandfather, aunt, uncle, granddaughter, grandson, right? And third degree is a, you know, great aunt, great uncle, cousin. Okay, so these are all considered close relatives, okay, in the cancer discussion. Any of these people have a diagnosis of breast cancer, prostate cancer, pancreatic cancer, and you're Ashkenazi, even if it's, again, the man that had the cancer, you have a very strong reason to get tested. Now, you may decide not to get tested, but if you don't get tested, we have to make believe like you're positive, right? Because we don't know. So if someone has, again, a family history as Ashkenazi, that woman should start screening at a younger age. Now, the general recommendations for breast cancer screening, which what I mean by that is mammography. A mammogram is an X-ray of the breast. Some women also get an ultrasound of the breast and together with the mammogram. And then there's a third type of screening, which is an MRI. An MRI is expensive, it's noisy, it can be annoying, and it can pick up a lot of schmutz, a lot of stuff that will, you know, be confusing, maybe need to be biopsied. The insurance companies don't like to do it because it's expensive. So we save this test, which is very sensitive, but sort of difficult to do on everyone. We save that test for women that are high risk. So again, just to recap, regular woman, go outside, pick any woman on the street. She's not Ashkenazi. She doesn't have a family history. She's never had breast cancer. She should start getting a mammogram at age 40. Okay, I will mention, just keep this in the back of your mind, some people say age 50. It's a little bit controversial, 40 or 50, but my recommendation is 40. You get a mammogram every year. If you have very dense breasts, you also get an ultrasound at the same time. But if a woman has the BRCA mutation or is suspected of having it because she has decided not to get tested at all or yet, she needs to start screening at age 25 with an MRI every year. That's really young. That's very, very young.
Wow. What about if they've screened though, if they've taken, let's say, the BRCA test and have come back negative, and obviously there is still a history that drove them to take that test. Are we putting them back to 40? Are we keeping them at the younger age?
We're putting them. So again, it depends on the age of, if somebody's mother died at age 32 from breast cancer and they test negative for mutation, they're still going to be considered high risk, right? And that's a woman who needs to be followed closely with a breast surgeon, followed in a high risk clinic, with a radiologist. And I'm just going to throw this in there. Pick a doctor that you like and stick with her, okay? It's very important to have that continuity. So it doesn't need to be a doctor who doesn't take insurance. It doesn't need to be a doctor, that, has a certain hospital, whatever. Find a doctor that you are comfortable with, that you like, that you're going to be able to go once a year, and that you're going to follow up with, because switching between mammograms, between hospitals, between MRIs, between physical exams, right? That physician needs to follow you very, very closely, and you need to feel very comfortable with them. So if you are a woman that is at high risk, whether or not you have tested, make an appointment with a breast surgeon, make an appointment with an oncologist, make an appointment with a radiologist, find a center, a doctor that you're comfortable with, and stick with them. And then that's it, you're in their hands.
Would you say, when you were saying a breast surgeon, you want people to be seeing them to get their mammograms through a breast surgeon or through an oncologist, or is this through a regular standard OBGYN? What are we telling people?
Yeah, no, so, OBGYNs are wonderful. They're great. Many women have their OBGYN as their primary care doctor. But a woman that has, is at a high risk for breast cancer should be seeing a breast oncologist. So, most of the time that's a breast surgeon, meaning a surgical oncologist. So it's a surgeon that specifically deals with breast cancer, and they will examine the woman's breasts, once a year. It's called a clinical breast exam. They will order the scans, whether it's a mammogram or an MRI. It's usually alternating, and will manage their care, So it's something that's an ongoing relationship. And the radiologist is the doctor behind the scenes who's interpreting the scans. But every surgical oncologist that I've worked with, will review the scans themselves. They'll talk to the radiologist. It's an interdisciplinary, we have tumor boards, we review everything. I routinely see patients like this as well. So any oncologist is going to be able to, take this on. It's not something that an OBGYN generally does.
Okay. That was just important because somebody had asked that. Okay.
Yeah.
Let's run through a bunch and we'll try to pack them in as much as possible. Other than lumps on the breast, are there any other symptoms to be aware of when it comes to breast cancer?
Lumps on the breast, any skin changes that are persistent, that don't change. Some breast cancers come on as what looks like a rash that doesn't go away. I don't mean like a tiny little spot. I mean like the whole entire breast gets red, gets inflamed. That's a very dangerous type of breast cancer. And unfortunately, very often it gets ignored because it sort of happens slowly over the course of a few months. Mm-hmm. So that is something that is an absolute emergency, needs to be seen right away. Any changes, any nipple changes, so nipple retraction, any part of the breast that becomes fixed. So the breasts are normally soft, they should be able to move. If they all of a sudden don't start moving as normally or get fixed to the, any area in any way, that's dangerous. Nipple discharge, bloody nipples, Breast pain, that's unusual. There are some women that have sort of like a twinge that's bothering them. Again, if it's something that comes and goes, you know, it happened once, that's unlikely to be anything, but something that's sort of persistent or different, definitely would recommend getting that checked out.
Okay. A few men actually, like some of the wives or even some of the men themselves asked, you know, they have a history of breast cancer and ovarian cancer within their families. Is there any purpose in their testing?
Yes, excellent question. So first of all, men who have the BRCA mutation can get breast cancer. Okay, men can get breast cancer. Second of all, men with a BRCA mutation are at higher risk for pancreatic cancer. They're also at a higher risk for high-grade prostate cancer. You know, prostate cancer is not something that we generally, you know, think about, worry about. It's usually something that is not that big of a deal in terms of a cancer type to have. But men who have BRCA mutation at a higher risk for worse types and more aggressive types of prostate cancer. Not only that, let's say a guy, his mother had breast cancer. Let's say she was never tested. Let's say he's married and he has a bunch of kids. He can pass it on to his children, right? So if somebody's mother died or father died of a cancer that is suspected to be related to a BRCA mutation, which again is any Ashkenazi man or woman who died of a breast cancer, a prostate cancer, an ovarian cancer, pancreatic cancer, if that person died, they cannot be tested anymore. So then we have to test the person who's next closest. So that means the children. Now, if somebody doesn't have children and they say, you know, if I get a cancer, whatever, we'll figure it out. But what about your children, right? There are things that we can do. It's not just about knowledge. It is not, you know, it's very different than if you think about, you know, when you're pregnant and they ask about prenatal testing, right? And this question comes up, why should I get tested? I'm never going to get an abortion. I'm never going to do, right? People say things like that, right? And I understand that. This is not the same thing. We're talking about having a knowledge that you can do something with.
Right.
You can
that
have
there are
children.
enough options. I think people assume that there's only one option open to them, and that is either a hysterectomy or stuff like that. Right. That's not the case.
No.
Let's make that very clear.
What?
We had this conversation before, you and I, about the fact that there are, we're not going to go into all the options out there, but there are many options that exist, and people need to know that by testing, they're opening themselves up to the possibility of life-saving options that are not as extreme. And they can genuinely.
And I'm going to take a step. Let's take a step back. No one has to make a decision to get tested. The decision is to go see an expert, a physician, or a genetic counselor, and have a discussion about risk.
Right.
That's what we're talking about here, right? We're talking about, hey, I have cancer in my family. I'm worried about this. Right. The next step is not, I'm getting my breast removed and my ovaries removed. Right. We're not, right? That's not the next step. The next step is make an appointment with your doctor, get a referral for a genetic counselor. And when you have an appointment with your genetic counselor, let me tell you, these are incredible professionals. There are many from women who are experts. They're genetic counselors. They receive an incredible amount of training. I work with them routinely. They will go over with you what your choices are. When you make an appointment to see a genetic counselor, that is not a decision to get tested. That is a decision to talk about risk and talk about testing and talk about everything like, should I get tested? What would I do if it's positive? What would I do if it's negative? Is my insurance going to cover this? What's it going to cost me?
Because that was another question people ask, you know, was this insurance covered? I can tell you that many of the insurances, you would be surprised, given a history, will cover it. I could tell you when I did my own testing, my insurance completely covered it. It was cheaper for them to pay to have me tested than, God forbid, to have me bill them for a whole bunch of other things that would have to be much more extensive payments. That was literally how calculated they are, which, by the way, knowing insurance companies in America and how little they pay for, they're betting really high stakes on the fact that they will save themselves a bucket load of money with this kind of testing, which should also indicate to us how far we can actually save ourselves, not just the money, but obviously our health by getting, you know, some level of testing. Okay, so we covered a couple of the other questions.
So I could tell you that unfortunately, I deal with insurance companies a lot because very often I'd like to recommend things for my patients that insurance companies don't want to pay for. I have never seen a patient denied genetic testing for breast cancer, except in a very rare circumstance where, you know, it really was just not indicated. It was like, for example,
I've seen with first degree and second degree relatives for the most part.
They
like
pay for it.
It's like this. Okay, so are these tests, just for the record, somebody asked, done in a regular lab, or are they done in specialty labs? Just somebody was curious about that.
Yeah, so let's talk a little bit about that. For someone that is going to get tested because there's a good reason, like you're Ashkenazi, like you are diagnosed with breast cancer, like you have a family member that was diagnosed, you have a good reason to get tested. See a genetic counselor or an oncologist. Do not order a test on Amazon. Okay, that is a bad idea.
Wait, they sell test kits on Amazon? You've got to be kidding.
They sell commercial tests for like $99. They have all different kinds of things. I'm not saying that everything about it is bad and stupid and unreliable, but a lot of it is. A lot of it is, and it's not going to give you an answer.
Coming back with a result that's not right and then scare the daylights out of you. Oh, that's not a risk I would take. Wow.
Right. So,
I didn't even know
it's sort of like when the coronavirus test started coming out. It was like, if it's positive, if it's negative, is it going to change anything? You know, if you have one of these tests, $99 on Amazon, if it's negative, it's not a reliable negative, right? And if it's positive, you're going to be running to a genetic counselor so fast, you're going to have a heart attack. So either way, just, you know, go see a professional, get a real good test, get a comprehensive test. That's the test that you need. And
that professional, hopefully, when they give you the results, because it's not like you're just getting this via text, will be able to do the follow-up that we need then. Okay.
Exactly. Wait, and one more thing, and just an example of where it's done. It's done in an office, in a consultation room. It's usually a swab in the cheek. It doesn't hurt. It's like it's basically like a Q-tip and it goes inside your cheek, and that's it.
Amazing. Quick question. Somebody said, so she's a girl who knows that the BRCA1 gene is in her family. What age would you test me? And is there a concept of testing too young?
Yes, so the recommendation is not to test younger than age 18 because we're not going to do anything, right? So we're not starting, you know, MRIs at age 18. We're not starting mammograms. The general recommendation for testing is at age 25, which is when, using that information, we would start yearly MRIs, yearly breast MRI.
Got it.
But again, if I would tell that young woman, even if she's 19 or 20, if it's something that's on her mind that she's thinking about, I would encourage her to see a genetic counselor. Again, it's almost always covered by insurance. In fact, usually hospitals don't even bill for it because it's sort of part of the services that they provide. So unlike they'll even get a hospital bill, go talk to a genetic counselor and say, hey, let's make a plan. This is what it's going to be like over the next 5 years. You know, I'll touch base with you and let's talk again then. It's worthwhile just to have that menuchas nefesh.
So somebody asks, and I know this is going to be a firestorm, so that's why I ask it. What would you advise a single girl? Won't carrier status affect my shidduchim?
I think it will. You know, I don't think it's different than other medical problems. I actually used to set a lot of people up back in the day. I made a few shidduchim with my husband. You know, things come up. People have things. People have issues. It's sort of something that most rabbanim, most shadchanim, in general, for health type of things, like other very personal things, you disclose when you're at a certain point in the relationship. At a certain point, it's something that needs to be discussed with the shadchan. Usually, is also discussed with, the person's rav, and you discuss it at that time. You know, it's just something that can be very scary. And most young women that are dating are too young to get tested. So it's usually a moot point. And again, we have things that we can do now, right? So women that have breast cancer, thank God, are living a long time. I treat women that have breast cancer, even with a BRCA1, BRCA2 mutation. We catch it early. No one even ever knows that they had a breast cancer. I really mean that. They never tell anyone.
Right.
People ask me all the time, I'm a radiation oncologist, so I treat cancer with radiation.
We took it for granted that everyone knows what you do.
Oh yeah, okay. Yeah, so I am a radiation oncologist, which means that I treat cancer with radiation, and I work at Montefiore in the Nyack location, so near Muncie. So I treat all different kinds of cancer, and one of the things that I treat a lot of is breast cancer. And when people ask me, isn't it so depressing that you treat cancer whole day? And what I tell them is that so many of the patients that I treat are cured, and no one even knows that they had a breast cancer because they don't tell anyone because they're still working full time.
Wow.
Right? They don't look sick. They don't act sick. So even women that have a BRCA1, BRCA2 mutation, again, the goal is doing the screening so that we catch it early, so that they don't have a breast cancer that they didn't know about and then die from, or an ovarian cancer, right? So there are things that we can do now. So to that young woman that was asking about shidduchim, I think it's important to think about for your own health when to get tested. And again, for most women, they're not going to get tested anyway until after they're married because they're too young. And having a mother that died of breast cancer is something that anyone going out with you is going to know about.
Yeah, I mean, right?
You can't hide that, right? So it is,
unfortunately. I want to take 2 minutes. I know you have to get off by 9:20. I want to take a couple minutes to fly through some of the comments here. So somebody said, what if a grandparent had cancer at a later age, never tested? Should we still be proactive? So I think that kind of ran into the category of what you're saying is just, it doesn't really matter any age. If a first degree or second degree or third degree relative has cancer, it doesn't, the age is not a factor, right?
For Ashkenazim.
Got it. Okay.
For Ashkenazim. So other women that have a breast cancer at an older age, we wouldn't test them for their children. But if someone was Ashkenazi, then yes, we would test.
Is there a test
no matter the age?
Is there a test for mutation for colon cancer and leukemia?
There are tests that we do on the tumor itself to look at how aggressive it is, what kinds of therapies, targeted therapies we can do. There are certain types of colon cancer that are hereditary, but again, it really depends on the details. There aren't any specific for everyone that had a colon cancer that we test for.
Okay.
Or anyone's relatives per se.
Got it. Somebody wrote, it's important to note that there are low estrogen birth control pills as well as progesterone only options. Talk to your doctor. I guess that's going back to our birth control versus elevating the risk thing. So, right.
There's so many different types. Yeah. There's so many different types.
Okay. Interesting. Are there Ashkenazi countries that are at a higher or lower risk? Like, meaning, I guess, the countries of origin. Interesting. I don't think so. Like, when I see it, they're all lumped together. Do you know that there was once a study done, I remember it was at the time that I took the test, which had to have been about 17 years ago, done by, I believe it was Bar-Ilan. It was one of the Israeli universities, that they were finding that people were coming in with higher, like, further stages of cancer who tested negative for BRCA1 and BRCA2. And they were trying to figure out why. And the results were astounding, is that when people tested negative, they stopped doing all screenings. They were like, okay, I'm scot-free. I never have to take a mammogram again in my life, which, of course, is baloney. So they said it was very interesting. for risks because they were being managed versus people who didn't have the mutation were simply coming in at later stages because there was no management of their preventative care. So I just thought that was interesting. And it kind of
Yeah,
drove
so
home.
if we talk about the numbers, you know, any woman in the world has a risk of breast cancer of about 12% over their lifetime.
Wow, wow. So somebody
Right?
was saying
So,
is that it's very important to find out about ants. Is that somebody found out about her history and then she went, you know, she did a mammogram and found out that she, I think, had cancer. Wow. Why does the age make a difference? Does the gene express itself at the same age in the, oh, the age you're saying, if the person died at 45, right? Why does that age kind of play a factor in the genetic piece? Like you were saying, you start the testing 10 years before that gene.
right. So the 10 years thing is more for colon cancer.
Okay.
But so there's two things, okay? Number one, remember we talked about how cancer is abnormal genes. So but you need two genes in a cell to go wrong, because if you have a normal copy,
Right.
then everything goes okay. So if you inherited a bad gene, how long does it take to get the second gene to be mutated? It takes less time.
Got it.
Right? Because
Wow.
if you were born with two normal copies, maybe one's mutated, but you're at least getting along with the other normal one, and then the second one needs to. So women that have a BRCA mutation very often have breast cancer at a younger age. And also, in general, breast cancers in younger women tend to be more aggressive.
Really?
And also, yeah, just across the board,
Mm-hmm.
women that have breast cancer, and again, this is not the case for every cancer. Like, for
Right.
example, for endometrial cancer versus uterine cancer, older women have more aggressive uterine cancer than younger women. For breast cancer, it's more. And then also, again, if someone has a mutation, they can have up to an 80% chance of developing a breast cancer. So what are we waiting for? Let's check, right?
Wow.
We want to check right away. We know that women can get breast cancer in their late 20s and in their 30s. So let's start screening. There's no reason to wait.
Got it. Wow, that's fascinating. Somebody asked, is it possible to screen while nursing? I guess she means a mammogram. Because a BRCA test with a swab, you can take at any time.
Right. Yeah, so usually women that are nursing don't get mammograms. We usually wait until they finish nursing. But again, that's something that should be discussed directly with the radiologist, depending on how old they are, when their last mammogram was, and stuff like that.
Yeah, and it depends also on the family history. I know that I've seen doctors go in different directions depending on their panic of, you know, another sister had breast cancer. Now we may want to do something real fast with you.
Right, exactly.
Okay. Do you recommend that people go to the same testing site for radiology each year, like in order to complete a mammogram? So I think that's what you were saying with the breast surgeon. But I think just to clarify is that it's the same radiology department. That's actually really important because people think, I mean, you take a picture. It's not like that. I mean, I've seen it. It's different people have different angles that they do and how they do it and their technique and whatever it is. And you can compare two and see, wait a second, I did this last year, I did this year. They're not looking much the same.
And exactly, to add to what you said, one of the most important things with screening, especially serial screenings, which is this every year, every 6 months, is comparing the two. If you go to a different place, they're not going to be able to compare them. Okay, right? So you want to have the old scans to compare to.
Somebody just asked this one, and I'm going to throw it in here. I've heard lots of tests like MRI, sonograms, mammograms. I was waiting for this question. Can cause cancer. Any validity to those claims? Oh, was I waiting for this one? I was actually shocked it didn't come in our first wave of questions.
Yeah. Okay. So we'll have to end with this, and then I want to just share the contact information for the
yes. So just to say is that you prepared an incredible PowerPoint with slides with a lot of information, and people were asking me where they can read further. Everything is in that PowerPoint. If you'll stay on a couple minutes after you leave, I'll tell people about what my experience was like actually getting tested for BRCA. It
Okay.
was about 17 years ago, so I know a lot has changed, but it just
Yeah.
was an interesting piece. Okay, go ahead.
Amazing. Okay, great. Yeah, so I put together some information in the form of a PowerPoint that has just a lot of visuals and also specific websites and resources that if you're interested in sort of getting into the nitty-gritty will be helpful to you, because I know there's a lot of information overload on the internet and it's important to look at credible information. So regarding risks of ultrasound, mammograms, MRIs. So only ionizing radiation can cause cancer. Okay, so meaning ultrasound is not radiation. It can't cause cancer. So ultrasounds are safe. MRIs don't use radiation. They're safe. Mammograms. So mammograms it's an X-ray, okay, so it does use radiation. It is not a therapeutic dose of radiation, meaning it can't do anything. It can't cure cancer. It's not like the radiation that I use every day to cure cancer, because the dose for a mammogram is extremely, extremely low. Now, this is a discussion about risk, okay? The risk of getting a breast cancer in any woman's life is 12% over their lifetime. The risk of getting a cancer from a mammogram, which is a tiny, tiny, tiny amount of radiation, lower than the amount of radiation you get from just walking this earth, because everywhere you go, there's small amounts of radiation, is way less than 12%, and it's way less than 1%. So I can't tell you that a mammogram never causes cancer, because maybe one time it did. Theoretically, any amount of radiation could cause a cancer, but have we actually seen that? No. We know that, again, any woman with breast cancer can get anyone with breasts can get breast cancer, okay? And that 12% of women in the world will get diagnosed with a breast cancer, and that risk can go up to 80% in a woman that has a BRCA1 or BRCA2 mutation. So is it a reasonable concern to worry about cancer risk from cancer screening? No, that is not a reasonable fear. And it should never be a reason for a woman to not get screened. Yeah.
Wow. Wow. Well, I think this was amazing. Thank you for sharing your time and information and that PowerPoint. I'm really excited.
My pleasure.
Doing the resources, and I think, like you said, getting our information from the right sources. Thanks a million for being with us today.
My pleasure. Thanks for inviting me. Have a great night. Bye-bye. And have an easy fast.
Amen. Okay. So that was really incredible, and I hope to be able to save this live right now. So since my battery is so low, I'll tell you the story of my testing in my stories. But in short, it definitely is a roller coaster ride till you get your results. Completely worthwhile, because it really, really, anybody who's had a first-degree relative or even a second-degree relative die of cancer, you want to be able to do whatever you can to see what you can do to protect yourself. And that's just something that we owe it to ourselves. And like she said, we owe it, those of us who are parents, we owe it to our children to test for their benefit. So thank you everyone for joining. I'm going to try to save this as an IGTV. Pray that my technology works. Take care. Good night.